maximum allowed guidelines or limits. So that's pretty great. There's no limit on reimbursement for screening that is age restricted at all. Most states do require billing underneath the child ID, but there are a few. So New York, Connecticut, and Ohio could be billed under either ID. So on that depression reimbursement table link, there's just a bit more information about modifiers, if caregivers can be screened, so other people outside of mom or birthing person, if they haven't required or recommended tools, and then the specified tool. And most often for states, they just require that it's like a EPDS or a PHQ-9, any kind of certified screening tool. We'll be sending out that more information. But yeah, feel free if you have any questions to reach out.
Thank you. And I am just going to stop sharing for 1 second because I just saw something that my recording has stopped, but it seems like it's still recording. So I apologize. Just checking on that. I think it's still recording. All right. Apologies. So going back, so kind of would love to have a discussion now of kind of if other sites are doing this, if you have been successful in getting reimbursed for maternal depression screening at well child visits, if you've tried, kind of what are some barriers facing, and then also, the list that Emily had and what's happening in Massachusetts could be very different of what's allowed and happening in your state. So start off with a question that Mario put in the chat. Was there discussion of whether the visit needed to be a well child or other visit? PA theoretically covers maternal depression screening outside of well child visits, which is not the implicit ICC model. I think, Julie, I think that may have been towards you for that one.
I think you can bill outside of the well child visit. It's gonna not prompt the clinician at those visits, but I think if someone recognized the child had missed a well child check and it was appropriate to screen, I think you still could definitely screen. You get the one-time payment. I think it's just during the first 6 months, so it doesn't have to be connected to a well visit code.
I should say that it's also implied that screening during a well child visit in PA is not reimbursed separately, because that's sort of just thought like that's what you should be doing at a well child visit. And so the only reimbursable services are outside of a well visit. So it's not that you should be screening outside a well child visit. It's just to make sure that you are getting covered for the additional service that you are providing during the well child visit, which is, what our ICC model is. But, I didn't know if that was a decision point in Massachusetts, like, should we do it during this type of visit or another type of visit? And I don't know why we seem to have done it in a different way in PA.
I think they're just trying to capture a lot of kids don't come in between their well child checks. Hopefully people are well, and this is the winter season. And it seems like maybe PA was taking the idea of just paying less money because there'd be fewer people coming in for those visits. I'm not sure. I think they just had separated the decision in Massachusetts.
I'm also curious because Tennessee wasn't on our list yet, but if Hannah happens to know what the Medicaid reimbursement model is like in Tennessee, that would be great too.
Yes, I just pulled up the NASHP website, and it looks like for Tennessee, let me scroll down to Tennessee real quick. It looks like for Tennessee, it is the rate varies per each MCO, so there's not consistency across that. looks like it is billed to either the mom or the baby's ID. And it provides the rates and the codes and stuff like that.
Scott?
I was just going to say, I haven't looked at this again recently, but like 4 or 5 years ago, we looked at some aggregate data on coding and billing for this, and we made a significant amount of money from this billing. The downside in New York is that you can't do this at an FQHC, but a CHC lookalike or other kinds of, a lot of our residency practices are not FQHCs, but they care for underserved populations, and so, we were making like several $100s over a few month period, which isn't a lot, but again, like Julie said, it is significant, and it makes people feel like the extra, quote unquote, extra work is valuable. So, and it is like pediatric clinicians and family medicine clinicians doing it.
Thanks, Scott. Yeah, I know part of our goal with some of this is trying to make this information more accessible. So I know through Amy, she had shared about New York not being able to reimburse for the screening at FQHC. So trying to, as a network, create kind of some of that information resource and disseminate so that if we do have members who are part of a state that has the reimbursement, helping them get to that point of achieving those reimbursement rates and bringing in some of that. So I think that's really kind of our goal as a network, and being able to show how other sites are doing it and kind of what are those best practices. Are there any other sites, or Julie, sorry.
I was just going to say something to Caroline's point about the PHQ2. There was at the table for the discussion of what was going to be paid for, and they just felt like the PHQ2 wasn't enough work to screen people, even though you would follow that up with a PHQ9. So that's where I think if you're doing implicit, you might want to do the EPDS instead for reimbursement, or the PHQ9. You might have to swap that out so there's not multiple screens being done if reimbursement is on the line.
Thank you. And yeah, just as a reminder for our network, we allow for the Edinburgh or the PHQ 2 and 9, and some sites only using the PHQ 9. So I think we definitely have those different pathways. Are there any other people on this call where you've been successful at your site getting reimbursed, or have attempted at your site to do reimbursement for maternal depression screening at well child visits? So I see in the chat about, I think we are getting reimbursed in North Carolina. Is there anyone else in North Carolina who can speak to that?
I've had so many fights with our IT department, and I think when there's a reimbursement, one of the ways I kind of try to get our health center to come on board quickly was I made a presentation of what $9 times all of these visits would be in terms of a number. It does add up quickly, to Scott's point, and what we could do with that money to help our patients in terms of support a community health worker, support additional staff that would help with this project. Sometimes that's helpful, but yeah, the money talks.
Yeah, I know one question that comes to the network a lot is, can we get reimbursed for the whole ICC screening. And I think that is our dream to get to that point where ICC is, you know, a standard of care across the country that you can get reimbursed for. But I think really trying to focus on what parts of it that are potentially reimbursable, like the maternal depression screening, and especially for sites that, you know, may be more limited in capacity or non-academic sites, and, you know, what benefit is this for my site to start doing this outside of, you know, the benefit to the patient, but, you know, how can I sell this to my health system and the higher ups? So I think that's kind of where a lot of this discussion and conversation has come from. Final question before we kind of move on, unless there's any other questions that people have, but is there anything as a network we can provide for you or that you think would be helpful to kind of better understand potential reimbursement for your site?
I'm not sure what what you're implying, but it would be helpful, I think, to figure out what the actual code is for each state, the service code, and then, I would ask a billing person, to say, can you just figure out if we're, look at this time period and do we bill for this service code, or how much, in terms of the total aggregate quantity or the number of times that it's been billed, those types of things. And I think that's when you find out if you're not capturing it, the EHR is not capturing it, it's getting dropped in the back end, it's being billed but not paid for. I mean, we work for organizations, I think, oftentimes that have, that recognize that they're not getting paid 70% of the things that they're billing for, and and just move on with that. And I think if we're trying to make an argument, we need to really figure out why it's not, and then try to push forward so that switch can get turned on. And I don't know that many of us do that. I certainly don't.
I think another thing to consider, so there's like direct reimbursement for screening. There's also the absence of reimbursements or the absence of bonuses for quality measures. And I think this is something that would be great to kind of think about with implicit in the screenings that we do on a state by state level. Like right now, this year, contraceptive intention screening is part of a quality measure for, I'm not sure what organization, if it's a federal Medicaid or it's for community health centers, but like the family planning question checks off that box. And so that has moved our health center to more fully integrated into the EMR. And the same thing with tobacco screening, that's part of other quality measures. And if your organization isn't doing them, they're probably losing money on some level. So there's direct and then absence as well. Thank you, Amy Hedis.
We're not using Epic yet, but are moving to that in the next few years. Is there anything within that, if you complete a smart form, does it automatically bill for a screening tool or a PAP or procedure or anything? Okay. Is that built into the implicit, like the ICC smart text? Because that might be helpful.
That's set up per site. It entirely depends on how your site is set up for billing, but it's yes, is the short answer. And it should be.
So it sounds like that would be something, maybe Amy, we can discuss, like potentially, a one pager on kind of how to have that conversation with IT at your site, and I think, again, that's also similar to what was said earlier from Mario of trying to identify what those codes are so that we can easily present them. I think it's also interesting to look into some of that more what Julie had brought up about some of the family planning and tobacco screening potential as well.
I think the code should be included in that table. So
Yeah.
it should be, yeah.
Any other final thoughts before we move on? So in the chat, Sarah asked, does that mean folks have a way to get billing automatic with a smartphone and Epic? We have to do a separate charge capture, I think.
Are you guys using Epic?
Yes.
So
To do a behavioral health like charge capture.
yeah, so
Oh, Amy, you just muted.
technically my cat did it. I am learning more and more about charge capture as 2 of my residents just started working at programs that use it, and we only use it for in-hospital accessory billing, and everything else we have built to drop off of things like smart forms and smart sets, and some places don't. So it would very, very much depend on what their build is. But I'm happy to look into it with someone.
And Rathika, I think I see your chat about not getting reimbursed through Medicaid, but some private payers. So I think that's definitely something we can potentially look into and work and see if we can get that reimbursement through Medicaid as well. Right. Any other final thoughts? Feel free if things come up or have questions, reach out. Like Emily said, we will be sharing this resource once we kind of fully put it together. And I think it really just potentially a resource to help sites, but also, you know, be able to help us better facilitate conversations with you and your site and billing departments and everything. All right. I am going to stop sharing. And real quick, before Mike starts, I am going to just, I don't know why the recording is coming. It still says I'm recording, so sorry. I'm just a little paranoid about that. All right, Mike, are you here?
Yep, I'm here.
All right, all yours.
Great, thanks, Anna. So in the next few minutes, I'm going to kind of walk through some data that I have prepared. So I know a couple days ago, I think Anna sent out a document that was attached to an email. So if you have that handy and want to follow along, you're welcome to do that. I'm going to kind of walk through that. The document is what's called an HTML document. It's basically something that you can open with a web browser if you're using Microsoft Edge or Google Chrome. So if you save it to a hard drive and then you can double click on it or right click on it, and you should be able to open it up with one of your browsers. So I'm going to, let me share my screen here. Okay, so earlier the data, well, I should say about 2 weeks ago, the data committee met and kind of gave me some instructions just in terms of what they thought would be most useful for us to cover. And so I'm going to be focused primarily on contraception and multivitamin. And in that context, they asked if I could specifically look at a cohort of births in the 2022 to the 2024 period. I specifically, targeted births because that allows at least to be able to include some fourth trimester information. So we'll take a look at that as well as we go through. They were also interested in specifically the behavior change with the new model that we developed. looking at interventions that are being done across the sites. We're also going to look at the contraception and multivitamin risk by the age of the child at visit, particularly for ICC. And we'll also look at some key elements that are typically included in the R report that you can get from Anna or any of the other project managers for your site or for the network. The final element they had asked about was breaking this down by some of our health equity variables. Unfortunately, in the time frame, I was just running out of time, and I didn't get this one done. But that can be for the fall meeting. So that's kind of where we're headed in the next few minutes, and I'll slide this out of the way. So this is the HTML document that Anna had attached. Just a little bit for some navigation support. There's a little menu over here on the left. So when you open it up in a browser, that menu stays up. So you can use that to navigate around the document. So you can just click on any of these links and it automatically takes you to the sections in the report. So you don't have to like scroll forever. Because these documents can get pretty long. So the report itself that I created for this meeting is based on a lot of things that are in our standard kind of R report that we send out for the network. So some of it, if you have ever looked at that report, you'll see some very familiar things. If not, that's okay too. And I won't be offended if you want to go get lunch. I know data presentations are not always everybody's forte, but if you want to go get lunch, you're free to go get lunch. But I have to say it is a privilege to work with the network and see all of the sites as you're reporting your data, to be able to summarize it and really be able to see some really interesting trends and information that comes out of this data on a regular basis. So the first part of the report is kind of a summary at a network level of our dyads, and I use the term dyad just to kind of represent the birthing person and the child. So if you see the term dyad in any of these reports, that's kind of what it's referring to. So this first table is really just a report out by site. The number of unique dyads that have been reported at each one of the particular locations. There's also a column in here that says dates of well child visits. So that's really kind of highlighting the month and the year based on the age of the child at the visit, and kind of at least giving you a sense of the time frame that we have recorded for each of the sites. You'll notice some dates that are impossible. Here's one. Broadway Clinic has a September of 2026, and usually this occurs either an incorrect month and year of birth or a age of child at visit that's incorrect. And then when it does the calculation, you get some really strange dates. So just be aware of that when you see those kinds of dates, it typically means there's some sort of a data entry error. So overall, if you scroll down to the bottom of that table, so for dyads where the birth was between 2022 and 2024, we have over 11,000 in the network database. So again, these are substantial numbers. This network has quite a large data repository of all of these ICC well child visits as well as the dyads. So it is quite an impressive database. The next table that's in the report starts to look at our screening rates. And so the way it's laid out, we've got the site. We have for each site, we have the total number of well child visits that are recorded. So again, this is any of the dyads where the birth was between 2022 and 2024. It gives you the total number of well child visits that site has reported. how many of those well-child visits included all of the ICC elements that were done, or a partial. So if, for example, during a well-child visit, you only had a chance to screen for depression, but were not able to screen for smoking, multivitamin, or contraception, that would be considered a partial ICC. And then finally, the column on the far right is the overall screen rate. So the denominator here is the total well-child visits, and the numerator is the combination of the all or partial ICC. And as a network, if I scroll down to the bottom, again, we have 47,000. So for this cohort born between 2022 and 2024, we have a total of over 47,000 well-child visits that are included in the database. And our overall screen rate is just shy of 70%. So the next section just gives a visualization by site. So the first graph here is just showing kind of how each of the sites visually compare just based on the raw number of dyads that are included in the database. And the second graph just shows the total number of well-child visits that are included for each particular site. The next table is kind of a summary looking at the well-child visits and our mother birthing person being present during those particular well-child visits. And so just kind of quickly summarizing this table, we have the total number of well-child visits, the number of well-child visits where the mom birthing person was present. So you can see for Broadway Clinic, they had 342 well-child visits, and there was actually only one of those well-child visits where they did not complete the mother birthing person question. And so of those 341, 304 where the mother birthing person was actually present at the visit. And that gives them an overall rate of 89% in terms of, so if you take 304 and divide it by 341, you get the 89% of their visits, the mother birthing person is present. And there were 267 well-child visits where all or part of the ICC screens were completed. And if you're calculating a rate based upon the presence of the mother or birthing person, that gives them a completion, a screen rate of 87.8%. So this screening rate here is based on the denominator of essentially only the well-child visits where we know that the mom or birthing person was present. And I think somebody said earlier today, some of the sites are not able to conclusively determine in some cases if the mother or birthing person was present at the well-child visit. So that rate, just be careful in interpreting that column simply because not every site is able to do that on a consistent basis. And overall, what I just want to point out here, overall as a network, we see just slightly over 95% of our well-child visits, the mother birthing person is present. So a very high rate of our encounters, we have that mother birthing person present. So that's an important rate to keep in mind. So as I mentioned, I was asked to focus primarily on contraception and multivitamins. So everything that I'm presenting from here on out is going to focus on those two particular risk areas that we screen for both in ICC and fourth trimester. And so this table is, again, a standard table that's part of the ICC report that we regularly produce. And it summarizes the contraception screen for ICC. And there are a lot of columns in this particular table. So just hang in there. So this first column is the total number of well-child visits. The second column is the number of well-child visits where contraception was screened. And so for the Broadway Clinic, they had a total of 342 well-child visits, and they screened for contraception in 247 of those particular visits. Of the 247 where they screened for contraception, there were 100 well-child visits where the mother or birthing person was at risk. In other words, they said that they were not using contraception at that particular well-child visit. And if you take 100 divided by 247, you get a risk rate of 40.5%. This column right here with the 97, that is out of the 100, where the mother birthing person was at risk, 97 of them had some sort of intervention documented, or they had filled out the intervention questionnaire. Of the 97, 35 had indicated that some type of intervention was done. And so for those that were documented, that gives them an intervention rate of 36.1%. And then obviously, of those 97, there were 100 at risk, but only 97 had a documented intervention. So that means there were 3 missing. And if you assume that the missing means no intervention was done, that gives you an effective intervention rate of 35%. So this last column will always have a rate lower than this column right here, simply because this last column is just saying any of them missing, we're going to assume that an intervention was not done in those particular instances. So if I scroll down to the bottom, again, looking at the network, how we're performing as a network, this column right here, 33.9%. So as a network, as a network as a whole, 33.9% of our well-child visits where contraception was screened we're identifying a risk. In other words, the mother birthing person is not on contraception at that particular encounter. And then of the interventions where it's documented, we're intervening 67.5% of the time. And if we include the missing as a no, that no intervention was done, that gives us an intervention rate of a little over 50%. There's a very colorful graphic at the bottom of each one of these tables. So when we implemented phase 3 in ICC, we enhanced our interventions to capture a number of intervention types. And this graph is just kind of showing you by site what are the types of interventions that are typically done. The gray represents no interventions were done. And then you have kind of the others. In this particular case for contraception, we have the purple representing those interventions where it was education materials, birth spacing, family planning options, or reviewed current method satisfaction. We have the blue representing a referral or to a follow-up appointment, and then the red representing providing birth control during the well-child visit. So again, you can see a lot of variability across the sites just in terms of what interventions are done and what proportion of those interventions represent each of the various types. And then for multivitamin, again, it's the same interpretation for this particular table. Total well-child visits, the total number where multivitamins were screened, the number of well-child visits where a risk was identified. In other words, the mother birthing person was not on a multivitamin. So in this particular case, the risk rate for this site is 58.9%. The number of instances or well-child visits when at risk that an intervention was documented, and 39 of those was some type of intervention was actually done. And then you have the intervention rate, and then the intervention rate, assuming that the missing means that no intervention was done. Overall, as a network for multivitamin, we see a risk rate of about 40%. And our intervention rate, when documented, was about 60.7%. And then if we assume that the missing interventions are not done, that gives us an effective rate of 44.5%. So the graph for multivitamin interventions, again, this represents what we have in phase 3 in terms of the number of interventions. I thought it was particularly interesting. There's a lot of red up here, and that represents a lot of the UPMC sites. And I had to wonder if the UPMC sites, relative to some of the others, have in their clinic rooms or whatever, have multivitamins readily available that they're providing them immediately during the well child visit. So it was just kind of an interesting observation, just compared with some of the other sites. Southside also has a really high red block here in this particular graph as well. So anyway, so just kind of a quick observation just in looking at some of those, some of the sites. So actually, let me just scroll down one more here quickly, and then I'll. So for the 4th trimester data, I did include that a snippet from that our report in this summary as well. Just looking at our risk rates for contraception and multivitamin. So for the 4th trimester data, here's just a summary of all the sites that are submitting data. So again, these are births that would have occurred in 2022 to 2024 for the 4th trimester database. And you can see the relative number of births included for each of the participating sites. And if I scroll down to the the contraception data, so our at-risk category is right here, the no method, from the 4th trimester data. And you can see the color coding represents which screen. So the purple represents prenatal, the blue represents at the hospital or the delivery, and the red represents at the well or the postpartum check. And you can see, for example, at the postpartum visit, the risk rate or mom birthing person saying they are not on contraception, 4.9%. And that's a lot lower than the ICC risk rate. And I think some of that has to do with our question in the 4th trimester is focused on current or planned contraception. Where at ICC, we're screening based on the current method. And so I think including that phrase planned in there adds some additional context in terms of how we're screening with 4th trimester is a little bit different than how we're actually screening for ICC. And then if I look at the multivitamin question, this is captured at the postpartum visit. So the in 4th trimester. So the multivitamin, those at risk would be this group right here. So about just shy of 16% in the 4th trimester data are at risk in terms of that multivitamin at the postpartum visit. So just as a quick summary so far, we have 11,000, over 11,000 dyads, 47,000 well child visits in this birth cohort 2022 to 2024. And our overall screening rate is about just shy of 70%. Mothers and birthing persons present at a well child visit is about 95%. For contraception, we're screening about 60% of well child visits, multivitamin about 63%. Our risk rate for contraception is about 34%. The risk rate for overall for multivitamins at any one well child visit is about 40%. And then in terms of documenting some sort of intervention, 67% for contraception and about 60% for multivitamin. I did include, and I'll send this additional information to Anna, and she can send this out. I'm not going to cover that today, but just in terms of ICC, in terms of what contraception methods are being used. So this again is a network summary for this birth cohort, showing you all of the well child visits and the types of contraception that are recorded at those visits. And again, for contraception, our definition of risk is if no method is identified. So that's what we're focused on today, just in terms of identifying when somebody is specifically at risk. And then just again, the interventions, those graphs that I showed you, there's a lot of variability from site to site in terms of what interventions are typically done. And again, I just wanted to highlight my note about the fourth trimester. Fourth trimester captures not only the actual contraception that is being documented, but it's also capturing what is planned. And so I think that probably explains some of the much lower risk rates in our contraception risk, that we see in the fourth trimester compared with ICC. Okay, so digging deeper into contraception and multivitamin, I had put these graphs together, I think for the fall meeting, and they're kind of interesting just because they show you kind of in two-dimensional space the distribution of all of the sites that are contributing ICC data. And so on the horizontal axis here, you have the risk rates for contraception. And on the vertical axis, you have the intervention rates for each site. Each one of these little dots is one of the sites, and the size of the dot represents the volume of well child visits. So the larger dots are representing the larger sites. So again, you see kind of a wide range of variability in terms of the risk rates across each of the sites, and then also a pretty wide intervention rate. I mean, we have some sites that their intervention rate is down near 0%, and we have some sites that are, intervening when a risk is identified close to 100% of the time. I thought it was particularly interesting when I looked at the multivitamin. This is the multivitamin graph, and there's actually almost kind of a linear, an inverse linear association here that the sites that have the highest risk rates, they actually have the lowest intervention rates. And so, whether it's some sort of just a random association, or if there's actually something in here that is suggesting that, if sites are intervening at in terms of multivitamin, if they're intervening at lower rates, their risk is obviously, potentially higher. And so it was just kind of an interesting association when I looked, across all of our sites. At the last meeting, I had also done some analyses looking at the other factors that may be associated with our mothers and birthing persons at risk, and what are some of those factors that could be explaining their risk at any one particular well child visit. So for this 2022 to 2024 cohort, I have included some of the demographic variables. So this first variable here is the well child visit age, and I'll just blow this up here a little bit so it's a little more visible. So we've got the age of the child at visit. We have all of our maternal education variables. We have the insurance variables. We have our race and ethnicity variables. And we have the mother age or maternal age in 5-year increments. And I have a variable in here called year, and that just simply takes the birth year and allows for, any potential change over time. And so what you see here is that education is a predictor of risk for contraception. And if the confidence intervals here, if this little whisker for any one of these bars does not include the red line, which is an odds ratio of 1, then that particular factor is statistically significant. So it's just kind of a quick summary here. We have education that has some association with, identifying a risk, a contraception risk at any one well child visit. We also have some of the race and ethnicity variables that are predictive, have increased, as an example, if your mother or birthing person is Black, that actually increases the odds that they're going to be at risk, contraception risk at any one particular well child visit. The mother age, if the mother or the birthing person, each additional 5 years of age actually decreases their risk of being at risk for contraception, or saying that there's no method of contraception. And I also found it interesting, even in our birth cohort of 2022 to 2024, essentially what this bar is saying that the births that the more recent past, I guess, actually have a higher risk of being at risk for contraception, saying that they're not using any contraception. So for multivitamin, it's a little bit different. One of the things is a big predictor here is the visit child age. So each additional month of the child age at visit, in other words, as the child gets older and is coming back for a well child visit, that actually increases the odds that you're going to find that mother birthing person is at risk. Education, we found that there are factors with education that are associated with finding a multivitamin risk. We had the insurance status was not associated with. Oh no, sorry, it was, yes, medical assistance right here. So medical assistance, you actually increase the odds that somebody's going to be at risk for not using a multivitamin. We had race and ethnicity. Some of those were associated with being at risk for multivitamin. The mother birthing person age, each 5-year increment increase in age actually decreased the risk of not being on a multivitamin. So it seems like our older mother birthing person, we're less likely to be at risk for not taking a multivitamin. And again, the year, it seems like our more current years, we're seeing less overall, or actually more risk of not being on a multivitamin in our most current years. So again, this is kind of the same summary that I did last fall at the meeting, just trying to look at some of the multivariate effects based on some of our demographic variables and what may be most associated with finding a mother birthing person at risk at any one particular well child visit. One of the other factors that is something that we look at a lot in our reports are just, at that age of child visit. I know we've talked about this at a number of the previous meetings that, particularly for contraception, as the child gets older, we may find that there are different risk rates because the mother birthing person may, as part of their family planning, may at some point decide that, hey, I'm going to attempt to get pregnant again, or I want to have another child. And so obviously they may be screened for risk later on in that well child visit cycle. So how do we look at across the age of the child visit and see how that risk might change over time? And so this this graph is kind of showing what those risk rates look like over time for both contraception and multivitamin. So the purple line is the contraception risk. And so you can see at the newborn visit, our contraception risk is, close to 42%. And notice how it significantly falls in the first couple months. And then you can see that it kind of gradually then, starting at about 12 months, gradually that we find more and more mothers birthing persons not on contraception after that particular time point. So this just kind of gives you a linear trend line of what that risk looks like over these well child visits. Multivitamin is kind of a very interesting. We start out below 30% and the risk just kind of skyrockets from that point on. So definitely something that multivitamin, immediately after birth is something that that's our lowest point of risk in that particular scenario, but it certainly increases significantly over time across our well child visits. The other thing is taking that same kind of approach and looking across the intervention rates. And one of the things we notice for both contraception and multivitamin is we do fewer and fewer interventions when the mother birthing person is at risk over time. And so, certainly, 70% intervention rate, right at, those newborn first couple month well child visits. But we, really tail off, down to 40% intervention rates, as you get out to the latter stages of well child visits. The next section kind of parses out some of this in a little more detail just by the age of the child at visit, just trying to look at it a number of different ways, hopefully to be helpful in parsing out some of this information. This first graph is associated with the pregnancy data that's kind of included in that contraception question as part of the ICC screen. And it's basically what's called a Kaplan-Meier curve that kind of gives you that cumulative percentage of mothers birthing persons identifying as pregnant as time marches on, and based on the age of child at visit. And so, just looking at the graph and interpreting it is if we kind of come out here to, let's say, around, if we come out here to the 15 to 17 month well child visit, and if you kind of run the line across here, so it's basically saying about 10% of our mothers birthing persons are pregnant again at that 15 to 17 month well child visit window. So it kind of gives you that perspective of that curve of what it looks like in terms of those rapid repeat pregnancies and when they typically occur, what proportion of our mothers birthing persons are pregnant at any one interval. There's a table included here as well. So if you want the breakdown of the the cumulative percentage pregnant, as well as the numerator denominator kind of thing, those are included as well. I also provide the so this graph here is just showing you the percentage that were at contraception risk at any one of the age of child at visit categories. This is basically just a bar graph of what I showed you up here. So it's kind of, it's taking this purple line here and extrapolating that out into a bar graph. So if you like looking at the bar graph better than a line, it also provides you the actual percentage and the the denominator for each one of those particular categories. So anyway, so that's included in here as well. And then I also provided just again another way of kind of thinking about this. This is actually what's called a risk ratio. And so if you think of this line here in the middle at 1, that is the essentially, if you think of that as just kind of the normative for all of our well child visits, regardless of what the age of child was at the visit. If we take all of our well child visits, that's the comparative line in the middle. And so for the newborn visit, the risk ratio is 1.44 compared to all of the visits. And so that's basically saying that there is a 44% increased risk of at a well child visit screening positive for risk compared with all of the other well child visits that we see. And it's so you essentially see that really that increased risk of contraception being a risk at that newborn visit. And then you see there's a block here of decreased risk relative to all of the well child visits, kind of in that 2 months to 15 month, and then you start to see that risk, climbing back to the mean. So yeah, again, that middle line you can kind of think of as the mean or the center point for all of our well child visits, and essentially it's just comparing with a risk ratio and a confidence interval relative to that mean, across time. And then finally, for the last kind of bar chart here for contraception is basically showing you the intervention rates across each one of those age of child at risks. So again, this is basically a bar graph format of this graph right up here. So the purple line here is just essentially represented in this bar chart here, showing you the actual rates for each age of child at visit, and then the denominator for each particular one. I also added some additional information here that's not included in our standard R report. This just kind of gives you an overview of the collective network for this cohort, what our interventions look like. So overall, for any time that a mom birthing person was at risk, it looks like we do not do an intervention 32% of the time. So that's the gray area. We're doing education materials, reviewing current method satisfaction. We're doing that, just shy of 50% of the time. We're doing referrals to follow-up appointments about 16% of the time, and we're doing providing birth control at the visit about 3.6% of the time. And then finally, for contraception, what I did is I broke it down by the age of child at visit. So again, as time marches on, with any particular dyad, we're doing less and less interventions, and you can again see that with the gray. You can see how the gray is increasing over, as we head towards the 24-month time window. But this just kind of gives you that just in a little bit different format, and it also breaks it down by the specific types of interventions that were done. I mean, the light blue and the red look fairly consistent across time, but again, just another way of looking at those interventions that we as a network are providing. And then the next section just runs you through the multivitamin. I won't spend as much time on this one because again, the interpretation is the same. This is the same as that line graph, just showing you what the risk rates look like over time. And again, with multivitamin, we see a very low risk rate at the newborn visit. And then that risk rate really starts to kind of ramp up as you get closer and closer to the 24-month well child visit. And same with the risk ratio scale. This one actually is a really nice kind of a curved scale. But again, think of that middle line here as the mean or the center point for all of our well child visits in terms of finding a risk at any one of them. And then each little dot and whisker with the confidence interval just kind of shows you what that risk is relative to that mean. and how much lower that risk is kind of in that newborn to 2-month window, and then the risk, kind of escalates above that mean line as you head on out. The multivitamin intervention rate. Overall, how we're doing just in terms of the types of interventions. So again, looks like about 53% we're actually just recommending a multivitamin, and then we're providing some sort of voucher or script of about 3.3% of the time, and then we're actually giving multivitamins at the visit about 3.7% of the time. And if we look at that by the age of child at visit, again, you see that decreasing, or I should say increasing, no intervention done with the gray, and a pretty consistent red and blue mix with the purple, across all of the ages of the child at visit. So this is a section I wanted to make sure that spent the most time on, just in terms of or at least for me, I think I found something that's kind of interesting here that I wanted to make sure we highlight. So this is the behavior change section, and this is based on kind of a new methodology that we deployed back over the last 2 years or so. And it's based on this concept of what's kind of an emerging hotspot analysis. And I had presented on this, I think, at the fall 2023 and the spring 2024 meetings. And essentially what it's looking at is we basically take each mother birthing person, and we're looking at all of their well child visits where they were screened for whether it's contraception or multivitamin. And we're basically taking all of those well child visit screens, and we're dropping them into categories, six possible categories. And I spell them out here in the text, so if you're following along, you can see what those 6 categories. So we have a category called always not at risk. And so this means that essentially for all of the contraception screens that they had over their well child visit window, none of them were at risk. And then we have intensifying non-risk. And in this particular instance, you would say, this would be an example of a mom birthing person who, maybe early on in the well child sequence, that they may have had a visit or 2 or whatever that they screened positive for a risk, but the latter trend is towards a non-risk state. In other words, they are linearly kind of decreasing that risk over time. And so I have a methodology that I use to kind of tease that out. And we have 2 middle categories, oscillating non-risk and oscillating risk. In other words, they're kind of jumping back and forth between screening positive for risk, not at risk, screening positive for risk, not at risk. And we can't discern any particular trend. And so if a higher proportion of their well child visits are not at risk, they're considered oscillating non-risk. And if a higher proportion of their well child visits are at risk, they're considered oscillating risk. But essentially, we can't discern any particular linear or any other trend from that. They're not trending towards risk or away from risk. They're just kind of fluctuating quite a bit. We have an intensifying risk classification. This just means that over time they may have started out of well child visits not at risk, but of the latter trend, there's a linear trend there that's basically saying they are more at risk in the latter stages. They're kind of in that intensifying risk. And then finally, there's a category called always risk. In other words, every well child visit where we screen them, they screen positive for that particular risk. And what we do is, to do this calculation, we require that we've divided their well child visits up into essentially 5 categories based upon the age of the child at visit. And to be included in this summary, of the behavior change, they had to at least had 4 of the 5 categories in terms of visits. So in other words, they had to have had visits in at least 4 of these time frames in terms of well child visits. So for this cohort of 2022 to 2024, we are essentially probably excluding most of the births in 2024 because they wouldn't have had visits up in these, upper to at least, for the most part, most of them wouldn't have visits up in these upper 2 categories. The cohort here that is included in this particular summary is only about 2,346 mom birthing persons. And if you remember, we had like 11,600, I think, included in the 2022 to 2024 cohort. So this is a much narrowed cohort, probably mostly births in 2022 and maybe early 2023 that are included in this particular summary. So let me scroll down to the actual showing you some of the behavior change results. So for contraception, this is what it looks like. So this purple bar here, the 6 categories are classified here. The purple colors are to represent more of the non-risk side, and the kind of the orange colors are representing more of the mom birthing persons at risk. And essentially, we had 34% of our mom birthing persons that across all of their well child visits never screened positive for contraception risk. And then down here in the bright orange section, we had 5.8% of our mom birthing persons that essentially every time that they were screened for contraception across all those age categories, they were always at risk. And then you see kind of the breakdown of all of the kind of intermediary categories. So we had, 13.5% are kind of in this intensifying non-risk. In other words, there was a linear trend, where they were decreasing their risk. Early well child visits, they were at risk. Latter well child visits, they're less likely to be at risk. So we were able to discern some sort of linear trend there in their the risk screen for this particular risk category. I break down by site. So you can see how your site compares. Again, there's a lot of variability. We have some sites with a lot of either the dark purple or a lot of the kind of the bright orange. So we have, a fair amount of variability across sites in terms of the makeup of these categories of either always at risk, always not at risk, and everything in between. If you want to know what your site is in any one of these, there's a table there that actually shows you the percentage and the denominator. So the percentage and the denominator in each of the categories, as you go along. But again, I'm emphasizing that this is across all of their well child visits. So it's kind of really a way of looking at behavior change within that mom birthing person. So what I also then did is I took the behavior change categories and I parsed them out by the breakdown of what interventions were done for these mom birthing persons that were in those categories. And so as an example for contraception, here's the group that's always at risk. So every well child visit, they screen positive for a contraception risk. 53% of the time they got some sort of educational materials, reviewing current method satisfaction. 12% of the time they got some sort of referral to a follow-up visit. 4% of the time provided birth control, and 31% of the time no intervention was done. So this is kind of an attempt to look and say, hey, do we see any kind of association between the interventions that were done and what categories these mom birthing persons ended up in terms of that trajectory of behavior change across all of their well child visits. And then to answer that question, if there is some sort of statistical association, I actually, constructed a model that created a weighted intervention score. So what I did with the contraception interventions, if you had no intervention done, you got a score of 0. If you got educational materials or just review the methods, you got a score of 1. If you got a referral to a follow-up appointment, you get a score of 2. And if you get birth control provided during the visit, you got a score of 3. So it's kind of a way of at least grading in intensity of that intervention across all of the categories. And if you do that kind of look for each mom and birthing person across all the interventions that they got and what behavior change group that they ended up in, statistically, it looks like as we increase the intensity of our interventions, that actually increases the odds that we're going to move those mom birthing persons towards the more the intensifying or lower risk categories. So as we increase that intensity of intervention, it looks like we're actually moving folks and doing less non-intervention. We're actually moving folks into those more positive longitudinal risk categories that we've defined here in terms of these 6 groups. I also thought it was interesting that based on the total screens, if we're screening more regularly, that also tended to increase the movement of our mom birthing persons towards those more positive or lower risk behavior change categories. So that was something very interesting that I found, as a part of looking at this and in terms of the interventions that we're actually doing and how that's maybe impacting what categories that our mom birthing persons are seeing. Multivitamin, the pattern looks a little different. We have, if you remember the multivitamin, we had a very strong trend towards higher and higher risk based on age of child at visit. So no surprise that our biggest category here is this intensifying risk. We have a much smaller number that are never at risk. But yeah, a very different pattern for multivitamin compared with contraception. If I look at it across sites, there's a lot more orange here and a lot less purple. But again, we tend to see this very steep increase in the risk for multivitamin across the age of child at visit. Similarly, with multivitamin, I did the breakdown of the interventions that were done by the behavior change category for each mom birthing person. And again, you kind of see that trend of for the intensify, particularly for the lower risk groups here, we have a lot less gray, but you definitely see an increased trend in the gray in terms of no interventions being done for our mom birthing persons that are more tend to be more at risk across our behavior change categories. And very similar to the the contraception outcomes, statistically, if we increase the intensity of our interventions, such as providing the multivitamins at the well child visit, that happens to move our mom birthing persons into those lower risk behavior change categories. And again, similarly, the more multivitamin screens we do, that also is statistically moving, associated with our mom birthing persons in lower risk categories in terms of behavior change. The last thing I'll just quickly show is from the standard R report. We had early on, when we were looking at behavior change, we were looking at it kind of as a well child visit to well child visit behavior change. In other words, if I'm at risk today for a contraception or multivitamin, at the next well child visit where that risk was screened, am I still at risk? So it's just looking at well child visit to well child visit and trying to discern if there's any impact with an intervention or not intervention. And if I look at this sub% column here, and so this row here are these would be the mother birthing persons that at the next well child visit were not at risk, and they didn't get an intervention at the previous well child visit. So particularly for contraception, looks like about 42% of them were stopped being at risk without an intervention even being done. And for those where an intervention was done, it looks like about 44% of them stopped being at risk at the next well child visit. So there's a little bit of a difference, but there's not a whole lot of a difference in terms of an intervention actually changing to the next well child visit to say that, hey, they're not at risk at that next visit. If I look at multivitamin, the difference is a little bigger. So for multivitamin, it looks like about 26% of them screen negative for multivitamin risk at the next well child visit. But if they get an intervention, it looks like about 36% of them screen negative at the next well child visit. So there's a little bit more of a gap there that perhaps an intervention with multivitamin makes a more of a difference at the next well child visit than contraception does. So that's what I have. I have 2 minutes. Any questions or thoughts, comments? That was a lot of data to dump on you. Hopefully you got some lunch and maybe took an afternoon siesta, took a nap during the data presentation, but happy to answer any particular questions.
Laura?
So as the contraception rate goes down as you get further out from birth, is there any way to pull out, by the time you're at the 18 to 24 month mark, like, they're trying to get pregnant? And really it looks like the only option is, was intervention offered or done? And the answer would be no, trying to get pregnant, but that's not necessarily a bad thing by the time they hit 18 months to 24 months.
Right. No, that's excellent point. And we've talked about that. I remember looking at that. It was quite a number of years ago in one of the spring or fall meetings. But yeah, certainly I think we could probably take a much more nuanced view of contraception, particularly in saying, hey, at a certain point, it may not be fruitful to look at it after this particular age of child at visit kind of thing. But no, excellent. And that may be something for a future edition of like the report or something to maybe either parse that out separately or or just build it into the overall contraception summary.
But then in those individuals, the folate, the multivitamin use should be going up and not down.
Right, right.
And I will just say as a caveat, asking Mike to look at contraception and multivitamin data focus was because we do have 2 different publications in progress working on kind of looking at this data a little bit further. So I think some of these questions are helpful for us as we, look towards that. Dr. Kabagambe?
Great, thank you. Mike, this was amazing. I know you said a person couldn't have gone to sleep, but no, this was so engaging that I focused and I really enjoyed it. So I have a couple of questions. One of them is, so I know the risk of contraception increases as the age at well child visit increases. So the question I have is, for example, is that risk in any way linked to whether a person had a child within those 24 months or so? In other words, were there an analysis that excluded people who had another child in that period? So that's the first question. The other one was about any real differences, for example, in race ethnicity of these mothers and how they are adherent to these interventions or the actual risk profiles. The third is on if you have any data on actual risk of birth outcomes or child outcomes uh, and demonstrating whether these interventions have started making those impacts on those outcomes. Thank you. I'll stop there.
No, excellent questions. And I think your question about like the birth, goes along with the previous one of just, they're trying to get pregnant again. And so we should probably exclude and for our general reporting, I mean, we basically are just looking at, kind of a yes, no, at risk, not at risk. But the contraception one, not only are they trying to get pregnant, but or have they been pregnant, and they should probably be removed from the denominator part of that. And so and that's probably something that the data committee could define and specify and say, hey, as a network, this is how we're going to define those parameters. Because right now it's just we treat depression, smoking, contraception, multivitamin all the same way. We use the same formula, the same calculation for all of them. And that may be something that that the data committee, I think, could help. I don't want to make those arbitrary decisions. I'll rely on the data committee to give me guidance on how best the network would want to incorporate that. In terms of the race and ethnic breakdown, I just, as I mentioned earlier when I started, I just ran out of time to really, and again, that would probably have doubled the length of this document to start parsing all of these things out by race and ethnicity. We do have the ability in the standard report to break down the behavior change by, so those purple and orange, we can break that down by race and ethnicity. And then we have a couple other parameters that we include, like insurance status. We can look at some of these by insurance status as well. So, but certainly, again, that could be a publication. It could be the data committee making recommendations, say, hey, let's include this as a standard option in our health equity section of the report.
Wonderful.
Go ahead.
Sir, just as a follow-up, really these data are so interesting and engaging, but I wondered, in those analyses, especially where you compute the risk ratios and odds ratios, would it make sense for some of the analysis to add the size of the well-child visits, the number of well-child visits, as a way to account for differences by site? Because I thought the risks varied a lot by the site, and I wondered what could be underlying that variability in the risks.
Yeah, there's if you go up to some of the previous tables, the denominators for each of the sites are there, and there's certainly a wide range of. We have some sites with, hundreds of well child visits every month, and we have some that may have 10 or 20. It's very small. So yeah, certainly we could, another standard you could say is we're going to combine for some of these at summaries, combine any sites that have less than 30 visits or something into one category. But in the display, we could notate them as with the denominator on there, so you give a little context of why they might look so different from some of the other sites.
We can also potentially, depending on the amount of well child visits or the number of dyads per site, we can run this R report specifically for a site. We just do have to be careful about the denominator. It has to be large enough in order to look at that. So that just for some sites may mean having a larger time period that we're looking at compared to other sites. I just want to real quick bring attention to a couple comments in the chat before we kind of move on and give Mike availability to kind of speak to any of those. So the first one was kind of going back to kind of the contraception, 35% no risk, asking whether we know the percentage with permanent sterilization. And then the second question is focused on drilling down on the payer source for those where intervention led to increased contraception use, wondering if uninsured patients may have increased contraceptive uptake after intervention versus those who had insurance increase access for their own appointments.
Yeah, Anna, do you want me, what I can do is I can respond to the chat questions so you can keep the agenda moving. So if that's okay, I'm happy to just sit here and I can type in answers to the chat questions, and then that way we're not getting too far off track.
No problem. I appreciate it. So feel free to also keep putting questions in the chat. And also, I know it's a lot of data, a lot of information. If questions come up, feel free to reach out. Or if you're interested in kind of looking at this for your site, happy to run these reports that are a little bit more site specific. So let me share my screen again. Thank you very much, Mike. Appreciate all your work on that. I think very excited to see where some of this data goes and with our publications. So, all right, the next section is kind of our last major section before we wrap up. So it's really focused on kind of taking some of the information we've talked about and having some breakout sessions. Before we jump into the breakout sessions, we're going to do a quick look at kind of the federal government, which I know is a hot topic on everybody's mind right now, and just the potential impacts and how we as a network are trying to respond to that. So I'll invite Christy to speak to the federal landscape.
All right. Anna, are you sharing your screen?
I am.
Okay, I can't see it.
So I'm on the current landscape slide right now.
Okay, all right. Minimizing it and bringing it back up worked perfectly. I don't know why. All right. So the current landscape, we are seeing a lot of emphasis on cutting spending and workforce in the federal government. In terms of federal grants, a lot of money from federal grants have been paused or frozen despite court orders. The NIH had moved to cut indirect funding that covers a lot of research and facilities and things like that to 15%, down from some schools get as high as 60, almost 70%. That was blocked by a preliminary injunction, but it's still a sign of where legislative priorities are. And also applications and grants with health equity, the phrase health equity or DEI language, are kind of not really being accepted, not really being looked favorably upon by this administration. In terms of federal legislation, we don't have a lot of major legislation yet, but we do have a budget resolution that passed both the Senate and the House, and there was a big emphasis on continuing tax cuts and cutting federal spending. And also, as I talked about a little bit before with the NIH move, a lot of administrative actions have been challenged in court, which causes a lot of uncertainty among patients and providers who are trying to, do their best in this landscape. So some implications for us in terms of future grant applications, depending on if we are applying to state or federal, private, we might need to change language depending on what we are applying to. In terms of publications, we might want to look more deeply into who we choose to publish with. And again, needing to adjust language depending on who we submit to, if we want to focus more on social determinants of health, more so than using the phrase health equity, things like that. There could also be loss of current grants. We've seen some stop work orders go out, not for any implicit grants, but for other federal grants. And we also want to look towards some non-federal funding opportunities, like state funding opportunities, private foundations, things like that. This also affects our ability to support network staff, because even if we don't look to federal sources for funding, a lot of places that were previously funded by the federal government are now also looking into other sources for funding. So our implicit network response really is we are continuing work and we are continuing to support sites in their work. And we really want to focus on disseminating information and connecting different sites and providers to facilitate discussion. Like I said earlier, in the health equity section, we crafted a statement to the network, which will go out soon. That statement is already on social media. We're also going to have an educational social media series on possible policy changes and how they would affect pregnant people. We're going to focus on hunger and pregnancy, immigration status, asylum policy, LGBTQIA policy, Medicaid, paid leave, insulin prices, and vaccines.
Thank you, Christy. All right, so for our breakout sessions, just kind of, we're going to be splitting into 3 groups with, ideally, if I do this properly, Emily, Christy, or myself should be in each section so that we can kind of try to help facilitate some conversation. So please just be aware that we are going to come back and would love to kind of have a little bit of a report back. So you don't have to necessarily designate someone to take notes, but just like, you know, kind of be aware of that when we report back. We'll probably do closer to about 10 to 15 minutes to discuss, and we'll keep communication so that if things seem to be wrapping up sooner, we'll come back. So the kind of prompts, and we'll make sure that each of these question prompts kind of go into your breakout session, but really wanting to give the opportunity to have some small group discussion. So first, having space to really talk about ICC or 4th trimester. So if you have any questions about stuff that have come up, barriers, troubleshooting, best practices at your site in regards to ICC or 4th trimester, giving that space to, you know, ask the other providers who are doing it for any advice, best practices. Also having a little bit of a conversation around the federal landscape. We really want to know how it's impacting your site and what are your immediate concerns, and then how the network can better support you and your site's work and the work for our birthing people and their families. And then finally, kind of going back to the health equity community partnership presentation is really understanding from you, would it be beneficial to create kind of a best practice document to help support local sites on their creation of community partnerships and sustaining that? And then also, how do you think the network could better work with some of these local partners that were presented? Things like sharing topic-specific resources with our network, presenting webinars, things like that. So I'm going to stop sharing my screen and then get you all in some breakout sessions, and then we will have a quick report back and then a couple final topics, and then we will be ending for the day. Stand by. Teams is working hard.
I was accidentally kicked out of my breakout session. Is there any way to get back in?
All right. Welcome back, everyone. I know everyone's getting tired and we're in the home stretch, but I think really some of these conversations are going to be helpful for us as coordinators to really, how can we continue moving this network forward and providing the resources that our sites need. So would love to hear from anyone about anything that they talked about in their group that they'd like to bring back to the larger group. Laura?
So our group talked a little bit about how we're approaching prenatal care in fourth trimester in the setting of undocumented patients and either their fear or hesitancy to get healthcare right now. And I know certainly even in Altoona, where we have a fairly small undocumented population, that they're just simply not showing up for their postpartum care. So we talked a bit about that.
Thank you.
And the solution was maybe offer more televisits so that they didn't have to leave the house.
Yeah, I think that was a theme that was brought up in our group as well, of just people being afraid to leave home or mistrusting healthcare, increase in vaccine mistrust. Are we seeing prenatal patients birthing at home due to fear? Is that anyone can kind of give any feedback on? I mean, I think something to maybe keep in mind. I know there is stories that I've seen out there of people not receiving care or going to get care during having miscarriages and that causing additional issues later on. And I think, that is a question that potentially, how do we address that? And I think, as a network, maybe our model of being able to really have some of these conversations of like screening, birthing people at the well child visits and checking in on their health, even if they may not be getting help for themselves, I think is a model that really leaning into in this time. Any other final thoughts about anything?
We talked about, I'm in Maine and there have been a lot of OB units closing. The one right in the same town that my clinic is based. So we got most of their OB patients. So our hospital did just over 1,000 deliveries a year, and the other local hospital did about 200 to 300. So it's a big increase from us, and patients also coming from much further away. So I'm concerned about people making it back for postpartum visits in that setting. So thinking about if there are sites that are more rural or spread out coming from a big catchment area, like how are you using telemedicine, home health nursing? Is there any public health nursing support that can help do some of the early, first 3 weeks screening?
Thank you. Yeah, I think that's a big conversation of the increase in maternity care deserts. And just, again, I think our model of care potentially has the ability to kind of address some of those needs of being able to implement ICC in kind of a more dyadic care model in some of the more rural health, family medicine or pediatric clinics. Any other final thoughts before we wrap up? All right. I would say just if people can reach out if there are certain needs that come up or you think something could be helpful with the changing federal landscape, if there's something that we can support you all, I think would love to be able to do that if possible. Yes. All right. All right, so just closing out. First, I want to just thank everyone for sticking with. If you were here the whole time, you're amazing. I appreciate it. I know there's a lot of competing things for your time and trying to block off this large of a section as clinicians and people in busy lives and jobs. I greatly appreciate it, and really your support and work with the network is very important to us. And I think the more that we can have some of these conversations and really have these meetings, it really helps us continue to move forward as a network. So just wanted to bring some attention to some upcoming events. So March of Dimes is, they do every year a March for Babies. Last year we had 2 implicit PA teams, one kind of in the Western PA, one in the Eastern PA. We're working to put together a Western PA team again this year. If you feel so inclined and would like to support the team, there's a QR code there. We also want to bring attention to other March for Babies events happening in different regions where we have sites. So these slides will all be shared, but definitely a great opportunity to just get out and kind of support what's happening. I think if you want to, if you can't attend any of these but are still interested in participating, you can join a virtual event or get more information. So that's just kind of one area of, as a network, really looking to try to have a little bit more community engagement. Upcoming committee meetings, data review, Tuesday, April 8th is our next meeting, 5:30 to 6:30 Eastern Standard Time. Health equity is Thursday, April 24th, 2 to 3 p.m. Eastern Standard Time. And scholarly activity is Wednesday, April 30th, 4 to 5 p.m. Eastern Standard Time. We're trying to do a better job of letting you know about these meetings. Attending one does not mean that you are signed on for the committee and expected to attend every one. But I think just hearing, if anything we've talked about today around some of these committees have you interested in doing a little bit of a deeper dive, we would love to have you join. It's really impactful for us to have different perspectives from across the network. So the more people we can kind of participate at different points from different sites, I think the better information and just discussion that we can have. So again, also a reminder, data review committee does not mean we talk about the nitty gritty of data all day. Like some of the questions that came up with Mike, some of those questions help us determine how to update our report or look at our data in a different way. And if you're interested in any sort of scholarly activity work or health equity work, please reach out. Again, we would love to have you participate. Our next meeting is our fall meeting, and we just want you all to be aware to save the date. It will be Thursday, September 18th. It is in connection with FMEC's annual conference, which is in Cleveland, Ohio at the Huntington Convention Center this year. This is a pre-conference to FMEC's annual conference. We'll start on that Friday. In past, we have tried to do 2 days, but with FMEC's kind of change in schedule, we do only a 1-day session, and we have to work around and also core session in the afternoon, which a lot of our providers also participate in. So really trying to make the most out of our time. It is a great opportunity to also meet with people after the meeting as well. As soon as FMEC releases information about their registration, I will be sending out an email to everyone to give you information on how to register. If you are not a part of FMEC and not attending the conference, you can just register for our fall meeting. Our fall meeting does not cost anything, so you will not have to pay anything unless you are doing the rest of the FMEC conference. So please be on the lookout for more information there. Also be on the lookout for upcoming webinars. Like I said, we're working on finalizing those speakers and dates, our website launch, and ABFM CQI information. So all of this stuff should be coming in the near future. We are also aware of some possible listserv email concerns with it reaching everyone. So if for some reason you haven't heard from us about one of these things or any information, please reach out and let us know. We're working to try to improve our listserv and make sure that everyone gets the information. Also, follow us on Instagram. A lot of what we talked about, some of our health equity stuff, we're really trying to expand what we're doing and how we're connecting to the general public. So that being said, thank you again. Appreciate all of you, and I know we are a little bit early, which hopefully feel good about getting 15 minutes of your day back. But I will stay on for a little bit in case anyone has any final questions, but thank you again for participating, and we look forward to seeing you in the fall.
Thank you all. Appreciate it.
Are you sharing these slides, by the way?
Yes.
And some of the data that I guess it was at Mike.